Good evening, everybody. Good evening to the people here, about 40 persons sitting in Amsterdam. And also good evening to many of you, more than 200 persons, who are present online today, this evening. It's really a pleasure that you're all willing and able to spend some time to talk about the topic for this symposium. And that is vaccine hesitancy and vaccination in elderly. And this symposium will have two parts, and they will actually be following each other. But before we start, I first want to say who I am. I'm Brenda Penninx. I'm professor of psychiatry at Amsterdam UMC. And this is not really my expertise of research at all, but I'm also serving as Vice-President of the Dutch Royal Academy of Sciences and Arts, and that's why I'm welcoming you this evening. So, two parts, as I already mentioned. We will start with vaccine hesitancy topic, which I think is really crucial. And I think we have experienced during the COVID pandemic what vaccine hesitancy is. If you look at all the reactions to vaccinations, the emotions, the behaviors, you kind of wonder what exactly is vaccine hesitancy and what can we do about it? And that will be a theme of the first part of this symposium. And without spending too much time, I really would like then to first introduce the first speaker. The first speaker is a PhD student from Radboud University Medical Center in Nijmegen, the Netherlands, Daphne Bussink, and she will give a talk on exactly the definition of vaccine hesitancy. So I would like to get a small applause and introduce Daphne to the floor here.
Yeah, thank you for this introduction, and good evening, everyone. Okay, about 2 years ago, I started working on my PhD on vaccine hesitancy. And in those 2 years, that actually became quite a hot topic. And this evening, I will share our research on the question, what is vaccine hesitancy? First, our research is funded by an organization, Zonnebek, which we're grateful for. And apart from this research grant, I have nothing to disclose. So I would like to start with this overview, showing that there are many steps in between the development of vaccines and before we reach the ultimate goal of vaccination, which is immunity at individual or population level. So there are many steps in between. And this final step of vaccine uptake is sometimes a little bit overlooked or taken for granted. And this is where our line of research is. And this also shows that even though we've developed vaccines that are very effective and very safe, that doesn't automatically mean that the goal of vaccination, which is immunity, is reached because people still need to be vaccinated. When we talk about the uptake of vaccines, we mean the percentage of a population that is vaccinated. And this rate or percentage of a population that receives the vaccine that we call uptake, that is influenced by many different factors. And in general, when uptake of vaccines is low, the vaccine-preventable disease, the disease that is prevented by that vaccine, may increase. And that is well illustrated by the example of measles. So a few years ago, in 2019, we observed a worldwide 5-fold increase of measles cases. And that was largely due to increases of measles in the WHO regions, Europe, and also in the Americas. And this increase of measles was linked to a reduced uptake of vaccines. So in countries with prior higher uptake levels of the measles vaccine, that uptake rate started to decline. So vaccine hesitancy as a concept has been used in the literature and studied to explain that decrease in vaccine uptake. For example, in a European study that was conducted in 18 countries, on average, 28% of parents self-identified as being somewhat or very hesitant about vaccines. And this is just one example of many studies that have been conducted about vaccine hesitancy. So in 2019, the WHO published a list of the main threats to global health. And this list was about 10 threats to global health. And on this slide, I've presented only 4. So for example, on this list, there was air pollution and climate change. There was antimicrobial resistance. There was the threat of a global influenza pandemic, and also vaccine hesitancy. So in our research group, we were interested in studying research questions such as how many people are hesitant in our population, what are their characteristics, what drives vaccine hesitancy, and, for example, what are effective strategies to overcome this hesitancy. But soon we came to realize that we needed to answer another question first. And this question was, what is vaccine hesitancy? So we needed to take a step back and first look at what is vaccine hesitancy. So when we look at definitions of vaccine hesitancy, one that we often come across in the literature is the one that is proposed by the WHO SAGE group in 2015. This is a very broad and inclusive definition. And I quote, "Vaccine hesitancy refers to a delay in acceptance or refusal of vaccines, despite the availability of vaccine services. Vaccine hesitancy is complex and context-specific, varying across time, place, and vaccine." So in this definition, vaccine hesitancy is described as a delay in acceptance of vaccines and also or refusal. And furthermore, vaccine hesitancy is described as being complex and also depending on its context. So when we further look into the literature how this concept is used by different researchers, what we found is that there was a lot of overlap in terminology and interchangeable use of terminology. So for example, in studies about vaccine hesitancy, that was sometimes defined as people having a low confidence in vaccines, sometimes being defined as people unwilling to be vaccinated, sometimes defined as a low uptake of vaccines, and even though that was due to people having poor access to health, that sometimes was still defined as vaccine hesitancy, and also people who had a low intention to vaccinate. So vaccine hesitancy became this umbrella terminology covering actually many different aspects, and that caused a lot of confusion. And researchers, including ourselves, were wondering what is exactly covered by this vaccine hesitancy umbrella. And this is problematic because when different definitions are used for the same concept, this will give rise to different methods that are used to, for example, measure what vaccine hesitancy is. And when studies use different definitions, different tools to measure, that causes research results that are not comparable because different definitions are used. And altogether, this is hindering progress in this research field. So we wanted to address this problem first, and therefore we conducted a systematic literature review, and we aimed to clarify that concept of vaccine hesitancy. Because in our view, clarification and uniformity was really needed. And the main research questions of that systematic literature review were, what is vaccine hesitancy? And next, how is it measured? So this slide shows the flowchart and overview of the systematic literature search. And it shows that that we searched 3 databases, being PubMed, database MBase, and PsycInfo. And we ended up screening 7,427 articles. And that is actually quite a lot. And that was because our literature search took place when there was a lot of literature published about vaccine hesitancy and the COVID-19 vaccines. So actually those numbers skyrocketed, and this is resembled also in the titles and abstract that we included. So we ended up including 422 studies. And of those studies, there was really a mixture of studies conducted in high-income countries and low-income countries were about different vaccines. Still, the majority was on COVID, and also from different research fields. Because vaccine hesitancy is a subject that is studied by many different disciplines, from both biomedical and social sciences. So in the next step, we conducted a qualitative analysis, meaning we made a selection of the fragments of these articles describing vaccine hesitancy. And then in a qualitative analysis, we coded those fragments and sorted them. And next, we thematically analyzed those fragments and their codes. And finally, this resulted in the identification of 3 themes. So we were able to sort all those definitions of vaccine hesitancy in 3 main groups. And those 3 groups were vaccine hesitancy being described as thoughts and feelings, vaccine hesitancy being described as decision-making, and the final group, vaccine hesitancy being described as vaccination behavior. So next, from each of these groups, I will give a few examples to illustrate a little bit more with some quotes from the original research. So this first example is about belief. And I quote, vaccine-hesitant parents are a heterogeneous group who tend to have beliefs that fall between those of vaccine acceptors and rejectors. And a next example is about reluctance. I quote, the majority of participants defined vaccine hesitancy as a reluctance to receive recommended vaccination. So now we move on to examples from the theme, from the group decision-making. This example is about indecision. I quote, the term vaccine hesitancy should instead only be applied to those parents whose deliberations demonstrate something akin to indecision. And then the second example is about degrees of indecision. I quote, vaccine hesitant individuals are a heterogeneous group who hold varying degrees of indecision. And the final group was about vaccine hesitancy being described as vaccination behavior. And the first example is about refusal. I quote, it, referring to vaccine hesitancy, was not consistently defined, and several immunization managers interpreted it explicitly or implicitly as limited only to vaccine refusal. And the next example describes actually many types of different types of vaccination behavior. I quote, such vaccine-hesitant individuals may accept some vaccines but refuse or delay others. So, first we sorted all those descriptions of vaccine hesitancy in those 3 main groups. And then from that sorting and organizing, we needed to move towards what is a clear definition for vaccine hesitancy. And we searched in those 3 groups of descriptions like what is a more constructive and pragmatic definition for vaccine hesitancy. And we used guidelines for good concept definitions. And that basically means that, that good concepts are ideally defined by a set of unique features that distinguishes them from other closely related concepts. So it is more clear how that concept of vaccine hesitancy is distinguished from other closely related concepts. To illustrate that, let's first have a look at the group of descriptions of vaccination behavior. What we found in this group is that vaccine hesitancy was described by all types of vaccination behavior. So people accepting vaccines was described as vaccine hesitancy, people rejecting vaccines was described as vaccine hesitancy, and everything in between. And it's important to realize that people may accept vaccination and with or without hesitation, or reject vaccinations with or without hesitation. So actually, to describe vaccine hesitancy with vaccination behavior is confusing, and it doesn't make it more clear. So we rejected that group of descriptions as a candidate for a definition. So next, the group that described vaccine hesitancy as being thoughts and feelings. So basically in this group, we found that these descriptions of vaccine hesitancy was how vaccine hesitancy was experienced or expressed at individual level. And those descriptions included, for example, people having doubts, people having questions, people feeling unsure, people feeling reluctant, and so on. So again, we found many different descriptions, and also those resembled how people experience or express that as at individual level. And also, again, these descriptions were not distinctive enough to define what vaccine hesitancy is. So also this group, this theme was rejected as a possible candidate for a definition. And then in our final group, where we found descriptions of vaccine hesitancy as decision-making, we actually found something quite different. In all these descriptions, we found a common element, and that was people being that was indecision, people being undecided, having degrees of indecision, what we saw in the examples. And that was actually the unique feature that we were looking for. So this is how we came to our conclusion, that from all those descriptions in these three groups, we found that in that group of decision-making, that we could best define vaccine hesitancy as a psychological state of indecisiveness regarding a vaccine decision. So hereby meaning, vaccine hesitancy is about people who are in this decision-making process about whether to vaccinate or not, and are stuck in that process somewhere, being indecisive, unable to decide. And yeah, that is like the main conclusion of our analysis. And so in my presentation, I've started with introducing vaccine hesitancy as a concept that is very broad and is used partially overlapping with other concepts. And we found that very problematic because it causes research results which we cannot compare, and is also hindering further research into what vaccine hesitancy drives and what effective strategies are. And those are important questions. So based on our systematic literature review and our qualitative analysis, we propose a more pragmatic alternative, and that is to define vaccine hesitancy as a psychological state of indecisiveness regarding a vaccine decision. And for us, that where vaccine hesitancy first was somehow this more intangible concept, now this is something that we can grasp and actually use in our future research. And for us, this is a solid base for our next steps, which include measuring hesitancy, identifying drivers of hesitancy, and also inform strategies to overcome vaccine hesitancy. So this was what I wanted to share with you this evening. I would like to thank the research team that I'm working with. Marlies Hulscher, she's here, she'll be next up. And also my co-promotor Janine Houtvast and Lise van den Berg and Olga Visser. I would like to thank you all for your attention. I'll be happy to answer any questions. And thank you.
Thank you, Daphne, for a very clear talk. First, I want to say that if people online have questions, they can raise that also online, and we will have a look at the questions that come in and be able to address that. We have a second talk that really closely follows the theme of Daphne's talk by Marlies Hulscher. But before we move there, maybe if there are some short technical questions about the talk of Daphne, then we can take them now. And otherwise, larger discussions we will have after the second talk. Yes?
I was wondering... thank you. My name is Blusset. I'm a pensioned physician. I was wondering why you don't put costs in your different schemes. Because costs, at least for the average Dutchman, is quite interesting. If something is free, then they usually argue that the thing helps. If you have to pay for it, it's questionable.
Okay, thank you for this question. I think you're raising the point of that costs and what people pay or not pay for a vaccine is determining the uptake of vaccines, isn't it? That is influencing whether people want to be vaccinated or not, isn't it? Am I getting it? Okay. So indeed, that is one of the determinants of vaccine uptake. But here in this research, we've looked into vaccine hesitancy, and we've analyzed the literature that described what vaccine hesitancy is. And we had an open mind, and we just included everything that was described as vaccine hesitancy. And vaccine hesitancy itself, how it was described in the literature, did not include any aspects such as costs. But in the broader context of vaccine uptake, it is relevant. But for the scope of our research, for vaccine hesitancy, we didn't come across.
Did you
Maybe because I think your question partly gets into the theme of what determines vaccine hesitancy and vaccine acceptance. So my proposal would be to have more of those discussions after the second talk, because maybe partly already the next speaker will be talking about determinants of what drives vaccine hesitancy and how to address it. So I now would like to invite Professor Marlies Hulscher, who is Professor of Quality of Care for Infectious Diseases, also at the Radboud University Medical Center in Nijmegen, the Netherlands. And she will be talking more broadly about vaccination acceptance, vaccination hesitancy, and how to address these.
Yeah, thank you, Brenda. Well, indeed, I'm Marlies Hulscher. I'm a professor of quality of care for infectious diseases, and I'm an implementation scientist. And for those of you who are not familiar with this type of research, implementation scientists study methods to promote the uptake of evidence-based healthcare interventions. So, obviously, obviously, an evidence-based healthcare intervention can only result in improved health outcomes and in improved health if professionals actually provide that evidence-based practice to the patients and if patients actually comply with that evidence-based practice. So professionals, both professionals and patients, have to do something to make evidence work. So implementation scientists build methods to help professionals and patients to actually do so in daily practice. And implementation science is therefore about behavior, and implementation science is about behavior change. And that explains why most implementation scientists have a background in behavioral sciences. Although implementation science is a rather young science, it's only 30 or 40 years old, we apply old sciences. So we apply theories and methodology from sociology, psychology, epidemiology, economics, etc. So implementation science is about moving evidence into daily practice. And in case you wonder whether that's really necessary, whether it's really necessary to help evidence find its way into daily practice, this slide shows how evidence transfers in the healthcare domain. So on the left, you see the basic research that provides us with fundamental new insights. And once such new insight finds its application, this innovative diagnostic or this innovative therapy is tested in a clinical trial. And if the clinical trial shows that the innovative care is better than usual care, this innovative evidence-based care will be provided to our patients in daily practice, and they will reach improved health outcomes. At least that is how it works in theory. So in practice, something goes wrong. So in 1998, a landmark study was published by Schuster and colleagues. So they performed a systematic review in which they included 48 US studies in which actual care was compared to evidence-based guideline-recommended care. And they included about almost 500,000 patients that received preventive, acute, or chronic care. And they had to conclude that only 50 to 70% of the patients actually received evidence-based care in daily practice. And 20 to 30% of patients received contraindicated care. So care that they don't need, that doesn't help them, that sometimes harms them and costs a lot of money. And the results were similar for patients receiving preventive, acute, or chronic care. And up until now, the literature always shows the same figures. So I'll just give you some time to let that sink in. So 50 to 70% of our patients receive evidence-based care in daily practice. So I think it's safe to say that evidence does not implement itself. So we really need to build methods that help to bridge the evidence to practice gap. Now, what would such an effective method be? Would it be information, education, training, reminders, feedback, financial incentives, organizational change? Many methods possible. So I'll start with the bad news. There's no one-size-fits-all method. There's no magic bullet. There's no method that will always be successful in promoting the uptake of any evidence in any setting. So that's the bad news. The good news is that we have behavioral sciences. Because from these behavioral scientists, we can learn how to build effective methods. Now, these behavioral scientists, they apply many different theories, many different models, and they're all different. But what they have in common is the assumption that an intervention is more likely to be successful in changing behavior if the determinants that influence that behavior inform the intervention. So, if we want to build a method that is likely to successfully promote the uptake of evidence into daily practice, we first have to understand what determines, what influences, what drives, what helps or hinders the uptake of evidence in daily practice. And so if we apply this thinking to the uptake of evidence-based vaccines, then an important question would be, what do we know? What are the determinants of uptake of evidence-based vaccines? Well, luckily, we know already a lot about determinants of vaccination uptake. So this is a model that was drawn up by the SAGE working group experts. And this overview nicely shows the large amount and the large diversity of determinants that influence whether individuals ultimately will take the vaccination or not. So the challenge for an implementation scientist would be to develop a method that increases the likelihood that individuals will take vaccinations. And how do we come up with such a method? Well, in line with the suggestions of the behavioral scientists, we would look at each determinant separately and find a matching solution to address that determinant. So, for example, if knowledge about the vaccine or about the vaccine-preventable disease hinders professionals to offer vaccinations to their patients or to individuals, then we will have to build an educational method to address this lack of knowledge. If professionals do not offer vaccinations to individuals because of a lack of appropriate facilities to store vaccines, then we will have to come up with a solution to either adapt the facilities or change the logistics surrounding vaccination. On the other hand, if a lack of knowledge on the vaccine or the vaccine-preventable disease hinders patients to accept the vaccination, we will have to develop an educational strategy for patients. Or if patients do not take the vaccination because they forget their appointments, we will develop a reminder system. And if patients do not take the vaccination because they're afraid of needles, we will train professionals to gain skills in appropriately addressing these fears. So as an implementation scientist, we will work on, and we'll, by looking at each determinant and coming up with a matching solution until the whole vaccination uptake puzzle is drawn. And now suddenly, in recent years, there's this new jigsaw piece. There's this new phenomenon of vaccine hesitancy. And maybe by now it becomes more clear why for us as implementation scientists it was crucial to understand this new phenomenon, this new topic of vaccine hesitancy. So now, thanks to the systematic review that Daphne presented, we now define vaccine hesitancy as a psychological state of indecisiveness. And this turns vaccine hesitancy into a determinant of vaccination uptake, for which we have to find a matching solution. And for addressing that problem, well, this is where the implementation science comes to help, because implementation science is also known as knowledge translation. So that's at the bottom of the slide. And knowledge translation has been defined as ensuring that stakeholders are aware of and use research evidence to inform their health and their healthcare decision-making. So indecisiveness may be a new concept in the vaccination acceptance domain. It is not a new concept in the implementation science domain. So from the beginning, there have been implementation scientists that were involved and interested in healthcare decision-making. And they have been developing and testing methods to address indecisiveness. And ultimately, they came up with so-called decision aids. And this is their definition of decision aids. And you can read with me. So they state that decision aids are tools designed to help people participate in decision-making about healthcare options. And they also explicitly state that a decision aid does not advise people to choose one option over the other, nor does it replace consultations with professionals. But if we take this to vaccine hesitancy, decision aids are probably effective methods to address the vaccine hesitancy determinant. And thanks to all the research that they have performed, we know now very well what constitutes a good decision aid. So a decision aid is mostly composed of three core components. And the first component is information. So if we were to build a vaccination decision tool to address vaccine hesitancy, We would have to come up with clear, concise and neutral information on the decision and the health problem at hand. And that means that we would have to describe the benefits, the harms and the consequences of both the vaccine and the vaccine-preventable disease. And we would not only use words to describe this information, but we would also have to provide numerical probabilities. So that would be the first component of an effective decision tool for vaccine hesitancy. A second component is constituted by values. Now, values are guiding principles that guide our life. So these are overarching principles. So they're not. They transcend specific actions or specific situations. And values work as criteria against which we compare our decisions. So people decide on what is good or bad, or people decide on what is worth doing or avoiding, based on the possible consequences that their ultimate decision will have for their most cherished values. Now, the problem with values is that the impact of values in our decision making is mostly unconscious. So we are not aware that these values help us decide. So the big challenge for if we were to develop a vaccination decision tool would be to make explicit for individuals, help individuals make it explicit what values in their life are important for their decision-making regarding vaccination. So that would be the second component of a decision tool. Then the third component are personal stories and experiences. Now, the experts, not all decision tools include stories or experiences. And the experts do not agree yet about whether they are actually helpful in decision making. But especially in high vaccination coverage countries, the vaccine-preventable disease has basically become invisible for people. So, thanks to the high coverage, we do not see the effects of the disease anymore. And as a result of that, we tend to underestimate the risk of the disease, and we tend to overestimate the risk of the vaccine. So in this specific case of a vaccine decision aid, I think it would be interesting to explore whether personal stories on, so real-life stories regarding diseases will help individuals make decisions about vaccination. Yeah? So take-home messages to conclude. I basically have only one take-home message. I really want you to remember there's no one-size-fits-all solution. And also no one-size-fits-all solution to promote the uptake of evidence-based vaccines. So we meticulously have to build methods to promote uptake. And probably an effective ingredient of that successful method would be for the subpopulation of hesitant people in our target population would be a decision tool. And that's it.
Thank you very much, Marlies, for, again, I think a very clear talk. I would like to invite both Marlies and Daphne to the stage here so that we can have, with both of them, some questions either addressed online or here in the audience. And I have a personal assistant on the first row here that will tell us whether there are some online questions. But maybe first see whether in the audience there are specific questions for either Marlies, Daphne, or both of them together. I think we have learned the complexity of vaccine hesitancy, vaccine behaviors, vaccine thoughts and emotions, but also we have heard about the complexity of the contributing factors to it and how to deal with this. So I think there are probably quite some questions to be asked.
Will my question be answered now?
I can.
And the question is the Dutch situation comparable to the situation in, for instance, the United States of America? Here everybody is insured, and here we know that the insurance companies, the terrible insurance companies that make it so costly, what we think, but internationally we do very well. If they don't agree that a vaccination should be paid for the whole population or for a part of the population, then we know that it's not worthwhile.
Yeah. So I think the question is clear.
Yeah. And so here you clearly see that costs. Here you clearly see that costs influence individuals taking the vaccine, yes or no. So, for example, if you look in the Netherlands, luckily, vaccinations are free of charge.
You know, and there are several vaccines that are very costly, that cost about a quarter or a fifth of your yearly premium, and they certainly are worthwhile for elderly, and not paid by the companies. And
yeah, I can only agree, because we know it would be a pity if people would not get a vaccination that protects themselves and hopefully also their surroundings. It would be a pity if such a thing as costs would hinder individuals to actually get the vaccine. So you are correct that costs are a driver, influence uptake. And yeah.
Thank you. I think we have more questions. I know there are questions online. There's one other question from the audience that we will do first, and then we move online.
Well, thank you. My name is Daniela Timmermans, Amsterdam UMC. I've got a question first for you, Daphne. Thank you very much for your interesting conceptual analysis of vaccine hesitancy. And I'm glad it resulted in the definition of it is related to indecision. So that's a good thing, I would say. That's a good thing. So people are more aware of weighing the benefits and the risks and what their values are. So shouldn't you promote vaccine hesitancy then? Because it's all about empowerment and making your own decision. So that's good. Wouldn't you agree? Of course, Marlies, that relates to your talk also.
Yeah. I'll wait for Daphne.
Yeah, thank you. So, I think what you're trying to say is that it's a good thing if people make deliberate decisions about vaccinations, isn't it?
Yes, yeah. Exactly.
No, I can't agree more. And it's important that people make informed health decisions. It's just where it may get problematic is if people just are indecisive and stay indecisive and are unable to decide because they have so much information. Yeah, that is, I think, the other side of being indecisive.
To address the barriers, of course.
Yeah. Would you like to add?
Yeah, like Daphne, of course, deliberate and informed decisions are crucial. But
I would not stimulate vaccine hesitancy, because we've heard many people in focus groups and interviews, and they describe, for example, that they get information and it's not sufficient. They start looking for information, and ultimately they're overwhelmed by information, and they end up really by flipping a coin to decide to vaccinate or not. And flipping a coin is not good decision making. So I would not propagate vaccine hesitancy.
One related question.
Well, very short, because we have also 3 online questions that we need to get to.
So in your view, it's also good that people do not decide not to vaccinate, because that's what a decision is about. Vaccinate or not vaccinate.
From an implementation, from an evidence-based healthcare perspective, a professional would be obliged to offer the vaccine. The person should be informed appropriately, and there should be discussion. But if we make it a free choice, then deliberation and information can result in refusing a vaccination.
Thank you. Mihai, you have the microphone. And
Yes, I have the microphone for a couple of questions from the audience, from the online audience. Could you give examples of values that are relevant to this issue? I guess the issue of vaccine hesitancies. So what are values relevant to the issue?
Yeah, for example, benevolence, so wanting to do the good for the world, could be a value that helps you decide, I think in this case, for vaccination. Or solidarity, wanting to also do good for other people than yourself, could be an important value that could play a role in decision making. Yeah.
Okay, thank you. Then the second question is, a decision tool made to promote uptake, can it be neutral? Because there is a goal.
Yeah, and that's a very good question. Decision aids, I think they started mostly in the oncology field, where people had 2 equal choices, you can almost say. So there's equipoise, that was a necessity for the various options. There should be equipoise. And based on information, patients could select the one that fitted their values and what they wanted to achieve in life. Now, a difficulty with vaccination is, of course, that you do not vaccinate only for yourself, but you also vaccinate for others. So there's this public health issue. So we've recently discussed this extensively. And yes, it will be challenging to provide concise, clear, and neutral information. But I think it should be possible. And you should pay as much attention to the vaccine as to the vaccine-preventable disease. And so it can be. It will certainly be difficult, but it's doable, I think.
Okay. Last question online, because I think there are more questions also in the audience here.
One last online. Facing patients with proof and numbers does not seem to help hesitant patients to make a decision. If they don't trust you, numbers and proof will not make a difference. What can we do on a level of feelings and beliefs?
Well, a decision tool, first, a decision tool can only do so much. So information can influence beliefs and perceptions. So yes, also with information you can change beliefs and perceptions. But there are many other ways to influence beliefs and perceptions. And those cannot all be included in decision aids. So yes, so again, a decision tool will not be a magic bullet to address the vaccine hesitancy.
It can help,
problem.
but it cannot solve it.
Certainly help.
Yeah.
Yeah.
Okay, I see two more questions. So Jos first.
Yeah, one of the
microphone.
one of the things that really amazed me during the whole COVID era was when the vaccine came, that there was no attention to people with needle anxiety, which is not uncommon. And actually, the real thing was we were boosting this all the time, because any item on television started with the upper arm with a needle going in as big as possible and as horrible as possible. And this was, to my mind, was a hidden persuader in the whole hesitancy, and also down the line, the waning of enthusiasm for coming in and getting vaccinated. It has been neglected so far, but I don't see it also in your system. Where is anxiety, fear in the system?
I didn't find it either, not in this overview. But that's why I included.
Let's see what you point.
I included here this is where I introduced the example of fear of needles, because
But I don't see it.
No, I made it up because I've read it somewhere else. There are many overviews, and none of them is so only if you integrate them you get the total picture.
In fact, even on this by the media. And that's also neglected. So it's not a stable trait. It's really getting worse and worse, to my mind.
So I read that 1 in 3 persons have at least some fear of needles. So that would also be an important, but it would be a determinant of vaccination uptake, not of vaccine hesitancy in this case.
There's another question, second row. Yeah.
Yeah, so maybe a short one. Thank you very much for bringing us a little bit into the world of decision-making hesitancy. But I was wondering, especially in your talk, Marlies, you were talking about the patient, and that implementation science was going to help us with maybe decision tool type of modules and methods. But a vaccinee is not a patient. So where does that difference come into your talk?
I noticed that sometimes I said patients and sometimes I said the individuals. But in this example of evidence of uptake of evidence-based vaccines, I should have spoken about individuals.
Yeah, because I think in a healthy person, the risk perception is, of course,
different.
More different. Different from a patient perspective.
Yeah, and that should be taken into account. Yeah, that was my fault. So.
Okay, I think we have a last online question, and then we move to the second part of our symposium.
Yes, the last online question is, what about a government which strongly promotes vaccinations? Are you free to go your own way?
This is what we heard in many interviews. So individuals said, I get an invitation with information, but that information comes from the same institution that wants as high as possible vaccine uptake. So how can I trust that information? So therefore I start looking for additional information. But then ultimately many people end up being undecisive and flipping coins to decide. So, yeah.
Okay, great. Well, thank you very much. We have to stop here and go to the next part of this symposium. I would like to have one round of applause for first two presenters. And I will now give the floor to Mihai, who will be chairing the second part of this symposium on vaccination in the elderly, and with lots of attention for the FEAM report that I'm sure he will introduce.
Thank you very much. It's a pleasure to be together with you here face-to-face, but also with the people online, of course. One very important subject we would like to approach this evening is also the subject of vaccination in populations of older age. Is that important? Is it not important? What are the components? Why do we think it's important? And what are the factors that make vaccinations in the elderly different, for example, than other age groups, for example, the newborn or the very young individuals? So FEAM wrote a report about that, and in this report we approach all these components. And in the next two talks, actually, we will try to put together information together with experts in the field regarding why is so important, for example, to vaccinate older population, and what are the factors influencing it. And we will start with Professor Jean-Pierre Michel, who is a professor of geriatric medicine at the University of Geneva, who will talk about the importance of vaccination older populations. And it's a pleasure to invite you and to hear your... Yep. Thank you.
So thank you very much, Mihai. I'm very pleased to be with you today, and I'm quite anxious about my talk because I don't know if I will fit with your different definition, but I think that I will. And I will try to give you a few values of vaccination in all adults. So if I have to put it here. The first thing that I would like to tell you to say is to speak about healthy aging. What is healthy aging? In fact, there is two definitions of healthy aging. The old one is, in fact, to be free of disease. And the second one, which is the most recent one, defined in 2015 by WHO within the first report on health and aging, is to be functionally well as long as possible to allow the well-being. But when we are speaking about healthy aging, we have to know something, that it is impossible not to integrate healthy aging with a life trajectory. And in fact, we have to speak about healthy lifespan. And in this context, it is necessary to know that all along our life, we will have interaction between two characteristics. One individual characteristics and one environmental characteristic. And today, the question which was asked to me is to know how vaccine can promote healthy aging. And indeed, I mentioned already that immunization uptake is very, very important. And during the COVID pandemics, it was true that we had a lot of problems with governmental trust, but also with misinformation. In this context, how we can speak about vaccination in old age and to increase the vaccination uptake? The first thing that we have to not to forget, which is too often forgotten, but which is very, very important, is that vaccine has anti-infectious effects. It decreases preventable vaccine disease, but also it decreases post-infection functional decline. And if you are looking at these different countries, Australia, Canada, United Kingdom, USA, you can see that there is an enormous decrease in disease morbidity and mortality from the pre-vaccine era to modern era. This is true for a lot of disease, but particularly the classical disease as congenital rubella, diphtheria, Haemophilus influenzae, measles, mumps, pertussis, rubella, and tetanus. And what is shocking is that there is two diseases which disappeared from the world, or quite from the world. And these two diseases are smallpox. And if smallpox disappeared in 1980 by the efforts of WHO, it was only because the vaccine uptake was 100% over the world. And when we are thinking about poliomyelitis, it is quite the same. It was in 2016 that poliomyelitis disappeared in Africa. There is still a few clusters of poliomyelitis in Afghanistan, but it is quite disappeared, and the rate of vaccine uptake was 100%. And WHO was extremely happy to say that vaccine have saved more than 500 million of lives during the last 50 years. And just before the COVID pandemic said that currently the vaccine averted around 4 million lives annually. And during the COVID pandemics, it was absolutely fantastic because it was estimated that in 185 countries, the averted number of deaths rose to 14.4 million, which is to say that vaccine against COVID was effective in around 63% of the cases. So it is very important to consider this and to notice that, in fact, whatever the problem, there is a lot of people who did not get the vaccine, whatever the recommendation for age or for different status. And if we are looking at vaccine-preventable disease in the United States, in 2015, it was noticed that there were 14.1 million of vaccine-preventable disease which occurred in this country. And when we are looking deeply about this vaccine-preventable disease, we have to notice that vaccine-preventable disease are much more often in old adults than in new children, because old adults are not vaccinated. And in fact, when you are looking in the same country, you can see that the uptake of pneumococcal vaccine is below 60%. The uptake of herpes zoster is below 40%. And globally, you can see that for people over the age of 19, the composite age vaccine appropriate is around 20%, which is very, very low. And the problem is that, in fact, vaccination are more indicated and more promoted in children than in old adults, than in adults simply. And what is the main goal? It is that there is an urgent need to bring adult routine immunization rates in line with pediatrics rates. Another main problem in old adults particularly is, in fact, the infectious effect of vaccine is also very important, because we have not to forget that infectious disease has a sixth cause of disability. And it was particularly true with COVID-19, but it was also true with other diseases, influenza infection and pneumococcal disease particularly. And a recent data published in Eurosurveillance shows that, in fact, flu is a very important cause, a very important burden of disability. And you can see the number of deaths following influenza disease. And also you can see that pneumococcal disease also increase the disability rate. And I found a recent study concerning RSV. We are speaking a lot of this disease. It is a very small study, about 300 participants, but these patients have the disease, and this disease was confirmed in laboratory. And you can see that they try to evaluate the functionality of the old people before the vaccine, and before the infection and after the infection. And you can see that in the different settings, and particularly in people living with assistance or in skilled nursing home, there was a very important decrease in function, and there is a lack of instrumental activities of daily living. And it is exactly the same for people in skilled nursing home when they got the vaccine after 2 months, 4 months, 6 months, they have a disability, which is a post-infection disability, which is very important. So we have to know the problem of the infection, but we have also to think about the problem of post-infection disabilities. And to fight against these post-infection disabilities, we have only the vaccine which are active. So if we are continuing our fight, our values of the vaccine and looking at the infectious effect of the vaccine at the community level, you can see that there is, at the same time, a community protection and herd immunity. And you spoke a lot of it in the beginning, in the first talk. I will show you 2 historical studies. The first one is in England and Wales in 1940. And in 1940, they noticed that they have a lot of pertussis. And when the immunization came, at that time, there was a decrease in incidence of pertussis. And immediately after, they had a lot of clusters with problem of pertussis. And it was completely in relation with the coverage rate, the uptake of vaccine. When the uptake of vaccine decreased, there was a cluster of pertussis. And it was exactly the same example that you gave, Daphne, in your presentation. A second very nice example that I love is in Japan. The Japanese government in the 1950s thought that, in fact, they have to do some things, but the global, the excess deaths from pneumococcal disease and influenza pneumonia. And they said, for the global population, and they said, we have to do something. And in 1962, they decided to have a program and to vaccinate all the school children with inactivated trivalent flu vaccine. And immediately after, you have a decrease in the global rate of pneumonia in adults and in children. And when the parents said, oh, well, we can refuse the vaccine, immediately this kind of problem of pneumonia increase again. And it shows something very interesting for us. It is the relationship between children and old adults, which is something that we have to think of because it is true for this pertussis, but it is also true for other diseases, and particularly for pertussis, for tuberculosis, for pneumonia, also pneumococcal pneumonia. But there is, because I am speaking about old adults, the problem of relationship between the healthcare professional and the patients themselves. And in fact, when you are looking at this study, which is a French study, which was one of the first that I know in this field, they analyzed 3,400 nursing home residents. Half of them got the vaccine, half of them did not get the vaccine. And the idea of the authors was to analyze the all cause of death in this population in relation with the level of vaccine coverage of the staff in the nursing home. And they identified 2 categories of nursing home with staff with a high level of vaccination and staff with a low level of vaccination. And what was shown by this study, that in fact, if you have to look for one nursing home for your parents, for example, you have to choose a nursing home where the staff is highly vaccinated, because here you can see that the decrease of global mortality, all-cause mortality, is much more lower in the nursing home where the staff is vaccinated. It was the first study which was published. There was another study which was very impressive and recently published concerning the United States, and particularly 12,000 nursing homes in the United States, e.g. more than 80% of the nursing homes of the countries. And they also tried to know if the people with the COVID vaccine, if the staff was or not vaccinated against the COVID. And they decided that to have a high level of vaccination of the staff, it would be over 80%, excuse me, it was over 80%. And if it is below 80%, we can say that it was not really very important. So if the staff is vaccinated, you can see that, in fact, the resident cases decreased by 29%. If the staff is vaccinated, the resident deaths decreased by 48%. If the staff is vaccinated, the number of problem COVID cases in the staff is decreased by 29%, showing how it is important to think not only of the resident of nursing home, but also of the staff of the nursing home, and probably to do something in this way. To continue my demonstration, if I can say that, you have to think about of something which is not really very well known, and which is also very important benefits of vaccine in all adults. The main problem that we have, and perhaps we will have to discuss later, is that we don't know exactly what are the mechanisms behind this kind of problems. And, excuse me, but it will be easier to speak after a glass of water. These different benefits are on cardiovascular disease, cardio-neurovascular disease, diabetes, and other diseases that I will show you in the next few minutes. The first thing to understand is that there was a Cochrane review in 2015 concerning 12,000 patients, and it shows that if you are vaccinated, your rate of mortality, the mortality rate is below than if you are not vaccinated, which was quite surprising. Another thing, which is also very important to notice, that people with heart disease, coronary heart disease, when they are vaccinated, they have low mortality rate. When you have people with this heart failure, the global mortality in people with heart failure who are vaccinated is below than people who are not vaccinated for all causes of death. And also, if we are, but it was now a retrospective analysis, it shows that if people got vaccination, flu vaccine, there was a decrease in the rate of stroke. Secondly, when we are looking at diabetic patients, concerning always the flu vaccine, patients who are diabetics and got flu vaccine have less pneumonia and respiratory failure, has less admission in intensive care unit, and also you can see that the all cause of mortality decrease in this patient with diabetes. More than that, it was shown, it was two studies from Taiwan, very important Taiwan contribution on this, that patients with COPD, chronic obstructive disease, and also chronic kidney disease have less acute coronary disease if they are vaccinated. And it is really very significant. So it is something that we can discuss, but it is proven now that there is this kind of effect. And to last, to show you that vaccine and flu vaccine is still always something that is important, there is a study which was just performed in 30 hospitals in 8 countries. And in these 30 hospitals in 8 countries, they decided to focus on patients who were admitted for acute coronary disease. And they have two groups, a group who get a flu vaccine during the 72 hours after admission, and a group who did not get any vaccination during the 72 hours. And the difference, the first primary composite show very clearly difference, the patients who are surviving as the patient who got the flu vaccine, which was very, very surprising, but indeed, you can see that it's true. It is true for all causes of death. It is true for cardiovascular death. And it was a very nice randomized control study performed just before the COVID, which include only 2,500 patients because the data were so clear to show the importance of flu vaccine in this kind of population. And this kind of data were followed by one editorial published in Circulation in 2021, saying that, in fact, perhaps flu vaccine is a very effective way to prevent cardiovascular disease when people are in acute coronary disease. So it's something that we have to have in mind, because when you are looking at other analyses and a very important field, which is the field of is Alzheimer's disease and dementia, Alzheimer's disease and dementia linked to virus and infection? It was always discussed. The discussion was started 30 years ago, and it is always very, very important. And you can see that in this meta-analysis performed by Nicola Veronese from Padova, you can see that there is also a problem that there is low incidence of dementia in patients who got the flu vaccine compared to the other. This kind of data are multiple, but in fact, it is very strange to know this kind of activities, and we have to discuss about how it can be, what are the mechanisms behind this kind of constatation. And to last on this aspect, I will show you that, in fact, and we know quite well this, that pneumococcal vaccines are less active on cardiovascular disease than flu vaccine, but small action. There is also herpes-zoster vaccination, which decrease the post-vaccine, the post-zoster stroke, and also, which was even more surprising, hepatitis B decreased the development of diabetes. And to complete in another field, which is the children vaccination, rotavirus vaccination in young adults decrease significantly diabetes type 1. How we can imagine that? So, to last my show, I think that I will show you that we have also concrete effect at the community level. And you spoke of antimicrobial resistance, and we know quite well that antimicrobial resistance is a threat, a very important threat, and we have to know that around 33,000 people die from antimicrobial resistant infection every year. And if we are speaking about antibiotics, we know quite well that this kind of effect is very important after the launch of all antibiotics. But for vaccine, we don't have this kind of effect, and resistance is not a significant clinical problem for vaccination. And what was really also very surprising is that with the introduction of PCV13, you can see that the decrease of resistance for macrolide was 60%, for cephalosporin, tetracycline, and penicillin more than 80%. And probably we missed the very important role that the vaccine could have as antimicrobial tool to promote and to guide. And to last, we'll show you this slide at the beginning, saying you that, in fact, in 2015 in US, they had around 14.1 million of preventable vaccine diseases. And the author of this paper calculated the cost of this 14.1 million of preventable disease. And in fact, the cost was around 9 billion. So when we were discussing about the cost of vaccine, at the community level, we can see that, in fact, there was big benefit with vaccination. What kind of take-home message can I leave you? I think that the first thing is that when you are thinking about vaccination of adults, you cannot speak only of old adults. It's not fair to do that, even for geriatricians. We have to speak about life course vaccination, which is something very important. Without that, there is no way. So when we are speaking about life course vaccination, we know quite well that for pregnant women, for children, there are very effective vaccination, precise guideline, and the vaccination is really well accepted. And we have a lot of knowledge about it. For adult individual and not patient, there is a big lack of recommendation. There is no recommendation. During years and years, adults have no recommendation. But we have now a lot of clues saying that it is very good to get the vaccine even when you are quite young adult. For patients with chronic disease, we have very precise recommendation. But in fact, the level of uptake is very, very low. And it is really a pity because we have good recommendation. They are very useful, but in fact, there is no way the uptake is very low. And to old adults, even with the effort of the FEAM and effort of all of people, there are no clear recommendation for the old adult and aging adult. And we know quite well it will be a very important preventive medicine measure to do that. And something that I learned recently, which shocked me a lot, because during the COVID pandemic, we know quite well that the 50% of deaths were deaths from patient or nursing home resident, 50% of them. And now, if we are looking at recommendation in nursing home, there is no recommendation for nursing home patient and their resident, and there is no recommendation for healthcare professional. So we know quite well that they will benefit of influenza and COVID vaccination, probably pneumococcal vaccine and pertussis vaccine, and if we'll go to more than that, we have to promote shingles vaccine. But the main problem of all this talk is that, in fact, what we have to do is to try to improve the vaccination uptake at any age of life. Thank you very much for your attention.
Thank you very much for this fantastic talk, and I think that a lot of questions will come in the end. There is one burning question that came from the online audience, is whether, do you think it's possible to achieve herd immunity when influenza vaccination, for example, is only 50 to 60%? The answer is in the question, basically. But yes.
The answer is very simple.
No. Yes. Thank you very much, and I think we'll move now to the next talk, which is coming from Professor George Griffin, who's presenting his talk online from London. Thank you for being with us. Professor Griffin is Professor of Infectious Diseases and Medicine at St. George's Hospital at the University of London. And he will give an overview in more depth of the FEAM report.
Thank you very much, Mihai. And what I'm going to do is tell you about a report, and you will get the reference for this at the end of my talk. And of course, there are references throughout on these slides that you can use. I'd love to have been part of the hesitancy discussion as well, and I hope I get a chance to add some of my views to that. But I won't do that just at the moment. Now, Jean-Pierre has given a great start to this, a very comprehensive view, and I'll be repeating some of his observations, and I'm going to try to give something of a mechanistic approach and think of the future as well. Just to say, I'm a practicing infectious disease doctor, and have a long association with KNAW-FEAM, and have helped with several reports from there, and have many friends in the academy. First of all, I'll just explain what FEAM is, and then move on into the science of my presentation. Next slide, please, Martin. Fine. Next slide after that as well, please. Good. Well, FEAM stands for Federation of European Academies of Medicine. It's a composite of 23 academies throughout Europe, initially just medicine, but more recently expanded to include veterinary medicine, the One Health concept, and to include pharmaceutical science as well as part of this continuum. SAPIR is Science Advice for Policy, which advises through the group of chief scientists ideas that come from special reports, which can be generated by organizations such as FEAM or other groups such as ESAC. And between FEAM and KNAW, we've produced some very important messages. I first came across Jean-Pierre when we were doing one of these major reports on transforming aging. And it was at that point when I was helping coordinate the excellent work that Jean-Pierre did. And you will get a reference for the transforming aging document at the end as well. That both of us realized just how important it was to emphasize vaccination for the older population. And FEAM produced a report that Jean-Pierre has mentioned already, which looked comprehensively throughout aspects such as the aging immune system that I will mention, through to vaccines that are available in Europe and regimens that are available in different European countries. And some quite startling things came out, particularly in the latter, and the discrepancies actually between countries and even within countries. And we will discuss that. Next slide, please. Now, first of all, I will just reiterate the importance of this. The deaths from communicable disease are still very important. As you saw those figures from Jean-Pierre, and the WHO are very, very concerned about this. And you'll see why this is important for WHO, particularly for developing countries. We started off by thinking that pediatric vaccine schedules are now very, very well established. And I could mention something here about the pediatric regimen in the UK, which is very important in terms of our first talk on hesitancy. We realized that even though there was a very good schedule, the last two vaccines of a triple vaccination schedule were often being missed. And was this hesitancy? No, it was quite simply that at 3 months after the first vaccination and then 6 months after that, parents who were busy quite simply were forgetting. And so we incorporated then what was called the accelerated vaccine scheme, which gave pediatric vaccines at 1 month intervals. The question was this as good in terms of its immunological efficacy? And it turned out it was just the same. And the vaccine numbers increased dramatically because of this. And I hope I get a chance to explain my views on hesitancy at the end, because it's not just as simple as indecisiveness. Now, the older population is clearly set to increase throughout Europe and indeed throughout the world. And I'll show you a graph of this in just a moment. And by 2050, this will have almost trebled. So we are talking of a vast number of people. Now, as Jean-Pierre has mentioned, the aging process is extremely heterogeneous across nations. Some people are completely disabled by all sorts of things by the age of 40. in developing low-income countries. We have a life expectancy, of course, in developed countries, which is now well above 75 years. So we are dealing with heterogeneity in aging. Now, just as a rough working number, the European Working Group consider old age over 65. C'est moi aussi, I could say. And 65 is now regarded as a retirement age in the UK, 64 now in France, as you've seen. So there are many years after retirement of working that we need to be considering in aging. Next slide, please. Now, this slide shows you the number of aging people, and this was over 60 actually, this prediction, for 3 groups of countries. The green group at the top are least developed countries. The major group you see with the yellow color, less developed countries, and the blue at the bottom, more developed countries. So you see this big growth that I've mentioned to you, almost a trebling, but being predominant in less developed countries. And we must not forget vaccination in these countries. And of course, in terms of COVID, there was a great furor at the beginning that vaccine was not available in these countries compared to developed. So a massive scale of growth in population, much more prevalent in the developing countries. Next slide, please. Now, Jean-Pierre has mentioned already the off-target effects of these vaccines, and I'm just going to emphasize those for you again and show how important these are. This is a study looking at the introduction of a 7-valent pneumococcal vaccine, a conjugate vaccine called PCV7, in children below the age of 5 in the USA. And it looked at antimicrobial resistance to pneumococcal vaccine. And you see that simply by getting effective prophylaxis against this infection, the use of antimicrobial agents in this population actually dropped dramatically. And you could monitor the reduction in the presence of antimicrobial resistance in this important pathogen, often a secondary pathogen, as Jean-Pierre has mentioned, in influenza. So antimicrobial resistance, which is a major healthcare challenge at the moment, as you all know, has had benefit from the introduction of pneumococcal vaccine, and this is proven. Next slide, please. Now, Jean-Pierre has mentioned the influenza vaccine as being a dominant vaccine for particularly in older people, and the off-target effects that this has. This is in cardio and neurovascular health, and he's shown that very well. The questions now to people like me who deal with immunology and vaccines and clinical care is, how does this work? And to be quite honest, we don't yet know. But it is very likely, and I'll discuss this with COVID at the end in terms of long COVID, that there is ongoing immunological change in individuals after these severe infections. And these add up to cause the pathology, which leads to cardiovascular and neurovascular diseases. So off-target events and effects are very important in vaccination. And in fact, influenza vaccine is not 100% vaccine, as many vaccines aren't. It diminishes the incidence and helps reduce the severity. But when you add the indirect protection, as you've heard, that increases the value of the vaccine. Next slide, please. Now, a little known effect or indirect effect of vaccines is BCG, and I'm going to explain about BCG in a moment. Brain neuroinflammation, a very hot topic, of course, at the moment with dementia and Alzheimer's disease and the formation of plaques. And it's very clear that people who've had BCG vaccination have either delayed onset of dementia of the Alzheimer type, or well, principally a delay, or even no development. Now, the mechanism of this, again, is indirect, but it's probably due to the fact that BCG is a very, we call it a dirty vaccine. It has many antigens within it, and it's likely to stimulate something called innate immunity, which is the background immunity which we all have, in addition to the specific immunity to discrete diseases. So again, another example of indirect benefit of vaccines on non-target diseases. Next slide, please. Now, many of you will not have seen this photograph on the left. It's a very interesting one, which I found. This is a photograph of 𝐏𝐚𝐫 and Guérin. They were microbiologists working at the Pasteur Institute in Paris. And they had the idea, because BCG was rampant then. It was rampant in animals, bovine tuberculosis, and in humans. And they had the idea that if they grew bovine tuberculosis in a weak broth, and you see here the vessels they used a thing called potato broth. If they grew the organism and multiply passaged it, you may weaken the organism. And when it gets to a weakened state, you can then perhaps use this as a vaccine. And after 100 passages, they produced BCG, Bacille, 𝐏𝐚𝐫, and Guérin. And this, they showed, protected animal models against bovine tuberculosis. And then they used it in humans and showed that there was some protection against TB. Not big protection, I should say. And we regard BCG as a poor vaccine in terms of preventing tuberculosis. It's found its métier, if that's the right word, by the surgeons who use it to instill into the bladder when they're treating bladder cancer, because it stimulates the innate immune system to help in the treatment of this disease. Now, on the right-hand side of the slide, you'll see the new vaccine, mRNA. And this is a huge advance in vaccinology. And I want to tell you how this came about and the great advance this has been for COVID. Old vaccines like BCG were the starting point. The organism itself, either alive or killed, was the vaccine. The next thought about 15 years ago was, well, perhaps we could use the DNA from these organisms to inject into muscle, and that might give a good immune response. And indeed, it did in mice. However, for humans, it took 10 milligrams of DNA to produce the desired immune effect, which was far too great, far too great. And then the idea came about, well, perhaps if we use messenger RNA rather than DNA, we might be able to get a good immune response. And this was a huge breakthrough. And quite simply by producing, as you see on the right-hand side of this slide, a virus-type particle which had got antigens in it and messenger RNA for those antigens, you could inject that into muscle and you could get fantastic immune responses with only 10 micrograms. Much, much better, much more usable. And furthermore, technology advanced so you could produce the messenger RNA to large enough quantity and purity to be used for massive population vaccinations. And this, of course, is what's happened with COVID and is very applicable to other vaccines. And now there are even work going on to reduce the amount of mRNA you need by adding other enzymes to these particles to increase the amount of RNA that's produced in the muscle and then into the immune response. So when you consider it took 100 passages in potato broth, and now it takes 100 days to get from from messenger RNA into a vaccine. This is a huge advance, and this is the big thing that happened with COVID. Next slide, please. Now, there are other advantages of vaccines that we're just beginning to realize, and the dominant one, of course, is in terms of cancer prevention. And the big cancer here is cervical cancer. And we know that human papillomavirus, HPV, which is sexually transmitted, is the biggest cause of cervical cancer in women. And vaccines now against only 9 serotypes, which are the ones which are known to be mutagenic in terms of cancer production, have shown that there is a fantastic reduction in cancer of the cervix. And by vaccinating early teenage males and females, and males are just as important as females, of course, in this respect, in terms of transmission, that the incidence of cervical cancer can be reduced by 95%. Now, this is a huge advance in oncology. And one of the things that FEAM did recently as a major report was to look at cancer screening for the EU. And we looked at screening for cervical cancer. And in fact, it's very likely that screening will only be in very high-risk groups of non-vaccinated individuals. So again, another fantastic advance in vaccinology. Next slide, please. Now, vaccine coverage rates, I'm sure we'll talk again about hesitancy, and which is a word I don't like, actually, as you'll see, throughout Europe for influenza. Only 2 countries in Europe have reached the 75% influenza vaccine rate. And Jean-Pierre has talked about healthcare workers versus, in conjunction rather, with the people are looking after in care homes. The UK and the Netherlands are the only 2 countries that have hit this 75% mark. And you'll see from these histograms, and I'm sorry the print is so small, but this goes down to virtually 0 in other countries. And it just shows that we have not yet used vaccination to its full extent. This, as you've seen, the off-target effects of influenza vaccine are great, and we could be doing a great deal for public health and healthcare in general if we can get this vaccine rate up. Next slide, please. Now, one of the things that we did, and Elisa in the FEAM executive did a very simple study looking throughout the EU at vaccination policy for older people. And Jean-Pierre has mentioned that the important vaccines already that are now available. And we found a complete disparity between different countries in terms of vaccine rates for older people, in terms of vaccine regimes for older people. And some standardization really should be carried out here at the EU level to ensure there is at the least adequacy of potential coverage, notwithstanding the elements of hesitancy that we've discussed already. So I will finish by saying it's very clear that vaccination in the older population is very important. There are specific infections which can be reduced, such as neurovascular, cardiovascular, that have been mentioned. And we should really be looking to increase vaccination in the older population. Now, in terms of COVID, I will just mention one last thing. There's been a lot of discussion on long effects of COVID. You get better from the acute disease, but there's long COVID, which is absolutely dreadfully disabling. Malaise, muscle aches, inability to concentrate. And there's the growing evidence now that this could be due to the long-term immune effects of COVID. And this is reactivating glandular fever virus, Epstein-Barr virus. And this is going to be a really important thing of the future, in my view, and means that we must keep vaccination levels up. And we must keep them up in older people to prevent a long-term chronic inflammatory process, which is going to be reactivating viruses like EBV and just through the inflammatory effects causing disability. So I'll finish at that point and thank you for listening. The references are all at the bottom of the...
Thank you very much, Professor Griffin, for this fantastic talk. And before we go to the general discussion, I would like to invite Professor Bart-Jan Kullberg, who's the chairman of the Health Council in the Netherlands, to share with us his thoughts after hearing all this interesting information.
Well, thanks very much, Mihai. So I've been given only 5 minutes, so I will not wrap up the other talks. And my kids taught me that there are much faster ways of making summaries of what someone else said. And well, this teaches us two things. First of all, that Professor Griffin is a very well-respected expert on the field, even in Silicon Valley. And the second thing is that he's very consistent in his talks, because last week AI would predict his conclusions. So rather than wrapping up what we heard, I think I'll focus on the program and the implementation in the Netherlands and see what the barriers are, even in this country where the uptake is very high, as we already heard. So the Health Council of the Netherlands, which I'm privileged to serve as a chair right now, is the independent scientific board, which makes recommendations, independent scientific recommendations in a wide variety of areas, including environmental health, legal, ethical issues, screening programs, but also vaccination. And most well known, of course, in the Netherlands are the National Immunization Program for children, but there are a number of other what we call programmatic offerings. There is still room for improvement, and this report was published 2 years ago now with a very critical appraisal of the programs in the Netherlands, and this may serve as an example for improvements that could be made in other countries as well. So let's briefly talk first about our national program for the elderly, as it's the topic of today. Influenza vaccination has been well established over 25 years now, including, as Professor Michel advocated, the residential institutions. I won't go into the classical comorbidities, cardiopulmonary, immunocompromised host, etc. But as you see, these programs are evolving, and even last year there were a number of changes and additions as a result of new scientific insights into specific risk groups. And you have already seen this slide before, this graph shown by George in black and white. I must confess that the uptake is not really up to 75% in the Netherlands. I think it's around 70% for the 65 plus, quite a bit lower for the other risk groups, and I think the lowest uptake is among the immunocompromised hosts, which may be only 50% or less. And I'll come back to that in a minute. Pneumococcal vaccination has been recommended by the Health Council now 5 years ago. From 60 years onwards, we are in the midst of a catch-up program where all the elderly 60 plus to 80 are being vaccinated, and as long as the PPV vaccine will be retained, after 5 years, revaccination rounds will start. Already now there are new recommendations pending, and I can't predict what will come out, but I suppose the committee will consider the newer conjugate vaccines, also the new ones, the 15, 20 valent, 21, 24 valent vaccines, reconsider the age limits. Hopefully there are new insights into the immunosenescence of the 80 plus, and so probably the age borders. Then varicella-zoster has been mentioned before. A program in the elderly has been recommended only when the new recombinant vaccine became available. The old attenuated vaccine was considered to be too weak to roll out as a national program. But the implementation of this program is still pending, probably because of financial priorities in the government. And then, of course, we have the COVID vaccination and our revaccination programs, which are ongoing. And these are based on what we call the application framework for COVID revaccination, which is a decision model taking into account things such as the virulence of the dominant strains, the herd immunity, the waning of the previous vaccines, etc., to decide whether or not specific groups should have or should not have a revaccination. And that's, of course, pending the considerations whether a long-term program will be necessary or not. Then there are different vaccination programs in the Netherlands. The first one is the public, mainly age-based program of programmed vaccination, which by law is recommended by the Health Council. The program for children is up to 18 years, and then we have national programs for the issues I already mentioned, influenza, pneumococcus, COVID-19, and now a catch-up program for 18 plus males and females for HPV, and in the upper program RVP for the 18 minus, there is also a catch-up program for those who were indecisive in previous years. Then there is this second compartment of what is called collectively insured care, which is covered by the health insurance, and I'll come to Dr. Blosset's questions about the payments and the cost in a minute, which is focuses at individual medical conditions, transplant, immunocompromised host, splenectomy, etc., which is another compartment and should be covered by health insurance. And then we have what we call the free market of individual prescriptions of the pneumococcus, the whatever vaccines that are on the market but not indicated by a national program to specific individuals. I won't talk about occupational health. Professor Michel has done so and shown the benefits of influenza vaccination and also COVID vaccination for healthcare workers and others. And these are also recommendations by the Health Council. Now, although we're doing quite well, there is, I think, quite some room for improvement. One of the issues is that the whole program or the programs are divided into these multiple compartments, multiple programs, multiple responsibilities, multiple ways of reimbursement. One issue is that the national immunization program for children, which has a very high uptake and is very well organized, that stops at 18 years of age. And that's why there have to be separate programs organized for instance, influenza, pneumococcus, etc., which is expensive and takes a lot of time and effort. The big divide is there between the age-based programs and the medical risk groups in terms of implementation and uptake. Also for influenza, I think that not all patients in the medical risk groups are sufficiently reached by GPs. Many GPs do a wonderful job in identifying their patients in medical risk groups, but others lag behind. But a bigger issue is in secondary healthcare, where there is no generalized recognition of the needs of patients in medical risk groups. They are not being identified on a regular basis. There is no registry. Medical specialties have no knowledge or interest maybe into how to deliver the vaccines, whether they can do that in their own clinics, whether they have to write a prescription, whether they refer to the GP, etc. And this is also not sufficiently integrated into treatment guidelines, which are about medical treatments, but often do not mention the vaccines. And then the reimbursement is divided into these various compartments. So the public funding is there for the national programs, but there are, as I showed in the programs for the elderly, significant delays between a positive recommendation and the rollout or the implementation of such a program. While medical risks are or should be covered by health insurance, age as such is not recognized as a medical risk and thus not covered by health insurance. And that's a reason, of course, for which the national programs have to be instituted, which are age-based. And then the free market, of course, causes, and that's what Dr. Blessé mentioned, inequalities in access and possibility to pay for vaccines that are not in the national programs. So a lot is going on to try to improve the system. Both the Health Council, the Ministry of Health, and the other stakeholders are working to improve the science for policy advice, speed and flexibility. The State Secretary has been very interested and actually announced a lot of improvements over the past year, recognizing the importance of vaccination for public health. One of the major proposals is to establish comprehensive vaccination centers at the municipal health authorities for any type of vaccination in adults, so from influenza to whatever catch-up program, to dispose of the 18-year age limit for the public programs, to improve the care for medical risk groups, which is a sort of general remark, of course, which remains to be seen how that works, and in general to rethink these reimbursement compartments and improve the access to the made-to-measure or free market vaccines and their reimbursements. So these are just proposals, and for those into Dutch politics, even this week there was a motion put forward to speed up the implementation of new vaccination programs for the elderly. So there's a lot of politics going on, and of course we hope, although it's not under our control, that things may improve. So this is, I think, a nice illustration of the barriers for implementation of a vaccine program, even in a country that is on the left-hand side of this uptake graph. Thank you very much.
Thank you very much. This was a fantastic overview. And I think, well, we are a little bit late, but we'll have time for a couple of questions. I think there was a lot of interest. And I would like to invite also Professor Michel to join us with Professor Griffin and Professor Kullberg. And if there are questions from the audience, first here in the room, and thereafter we have two small, I think, suggestions from the online. So I think there was a lot. Sorry. I think that there was a lot of information to take up. What I'm thinking as one of the important aspects, combining a little bit the efficacy and the hesitancy, let's say, is I'm thinking. Do you think that also at a certain moment, sometimes the hesitancy is based on the feeling or actually even the truth that some of the things that we know about vaccines, some of the things that we should know about vaccines are not known, and we should also put together programs that fill in those gaps in the knowledge. And I'm thinking especially at the novel, very important platforms of developing vaccines, adenoviral platform, messenger RNA platform, which are very quick, were for good reasons approved very quickly, but have raised also the question, what do we know about long-term effects? So I'm wondering, should we not include in our plan also trying to understand what are the long-term consequences of vaccinating an entire population with some new types of vaccines that we actually do not know so much as regarding the old ones? So what would be your thoughts?
I would like to say something because I was shocked during your presentation about hesitancy, vaccine hesitancy, that you did not stress something that for me is fundamental, is basic education and health education of the population. And at the French Academy of Medicine, I was the chairman of one report concerning education, health, and aging. And we were very surprised by what we found in Europe. Around 30%, if not 40% of the population in 8 European countries. The study was published in 2015, so there is no more studies since this date. But in 2015, in 8 European countries, the low level of basic and health education rise to 40% of the population. How this person who did not have any knowledge, basic knowledge or health education, can be able to understand messages about vaccine, basic vaccination, but also this kind of new technology, which is more complicated. So I think that perhaps we have to start by educating people and giving health education at school for.
No, I agree with that, but my question is about educating us, because some things we don't know. We cannot educate about things that we do not know.
Yes, but it is part of the question, because for me, it's something basic but very important. But after that, we can.
Any other questions? Yes.
Just a remark. This academy was very early on in the COVID epidemic, issuing a folder for the lay public, which was put into very easy language to explain about vaccination. The tragedy is then that we even had it translated into the languages of minorities in the Netherlands. But finally, the diffusion of a document like that is very difficult in a country. And an academy is not equipped to get into, say, the capillaries of the society enough. But in fact, the information is there. It's on our website. It was translated and put on the FEAM website as an example. And I still think we should take this on and keep continuing this way. And it's like George always says, educate, educate, educate.
Yes, thank you. So I think it's following your question, Mihai, also, that the knowledge about vaccines and their efficacy or effectiveness in the population is not a static thing. It's not. There is a lot of unknowns. We don't know, for example, what are the mechanisms of these non-specific effects that were presented quite nicely. But if we don't understand them, how can we then educate the population about the indirect effects of vaccines? So that's a bit difficult, I think. On the other hand, the nice data on effectiveness of vaccines and the prevention of a lot of cases and mortality, for example, just shortly after introduction of pneumococcal vaccination, that's nice and well. But now we all know that there is a lot of replacement that actually does alter that situation again, and there is not so much prevented by vaccination. So I think there is not a static truth about what the vaccines can bring us, and we also should be clear and honest about that, also when we want to educate the population. And that will be difficult then, probably, to really get your full or your optimal uptake. But maybe that's something that is good, because then people can make their own decisions based on what we all know, but we should really communicate in a complete manner about that.
Thank you very much. I think this is a very important point. Yes.
Thank you. My name is Rogier. I'm a legal scholar looking into the legal aspects of vaccination, more specifically health legal aspects of vaccination in the Amsterdam UMC. And I had a question for Professor Kullberg. One of your conclusions was that the Gezondheidsraad, the Health Council, is looking into rethinking the legal dichotomy between the collective and the individual. Following still, yeah, the legal dichotomy between the collective and individual good of vaccination. And I think this really bounds to the first question that was being raised about whether or not there is a reimbursement of vaccinations. And I wondered if you could maybe say a little more about rethinking this collective or individual good of vaccination, because legally this matters so much in the sense of whether or not, for example, adult vaccinations are being paid for. So I would wonder what the rethinking actually entails.
Yeah, well, actually, that was not a proposal of the Health Council, but thoughts by the Ministry of Health. And I think in general, the issue in the Netherlands, but probably also in other countries, is that there are various laws, the public health law, which is about the national vaccination program and public funds, public reimbursement, versus the health insurance law and the long-term health care law, which are about the insurance reimbursed vaccines. And these compartments are very strictly defined in terms of, does a vaccine is a vaccine for your own benefit, or does it serve a public health benefit? And of course, most of the vaccines do both. And there's the problem. I mean, pneumococcal vaccination in children has changed the, as we saw on the slide, the infection pressure on adults and elderly, and also even antimicrobial resistance. And this is true for many vaccines. So from a medical point of view, it's very hard to put a vaccine in one or the other box and resulting in a legal definition or obligation to reimburse or not to reimburse. So from a medical and immunological point of view, that's a barrier that has to be taken. And I hope government will take that up and do something about it.
Thank you very much, and I think that we've reached... Professor Griffin has one last comment. You are muted, George.
Not muted myself, I've been muted by... Can you hear me now?
Yes, we can now.
Good. Well, just a couple of things to say. The first thing is that infectious organisms are not static. They move and change. And when you eradicate one, another one will grow in prevalence. So you have to be aware of this all the time. Influenza at the moment is a different vaccine every year, trying to be ahead of the changes in the virus. There may be hope that there'll be a pan-strain vaccine quite soon for influenza, which would be a huge advance. The second thing is in terms of economics, and we have to bring in cost with healthcare, of course. Politicians, when they're thinking of new modes of treatment, always say, will this save money? And that, I'm sure, is absolutely right about vaccination. If we introduced a new vaccine, or if in the Netherlands, for example, the over 18 rule was abolished, would this increase the cost to the nation, or would it benefit the cost of the nation? And they would think in that way. And it's up to the immunologists and the public health doctors and so on to work out the health benefits. And if that coincides with a beneficial financial state, the politicians will take it without the slightest doubt. In the UK, vaccines are available free of charge at the point of delivery, except for exotic ones like yellow fever and so on. But for all of the vaccines that we've been discussing today, the population can have access to those. But the financial considerations, I agree, are very important. And in the Netherlands, you will have to work out for the politicians if this is cost effective. Over.
Thank you very much, and thank you everyone. It was a wonderful evening, and thank you for being here, and of course thank you to the speakers for their fantastic talks. Thank you.